morning, everyone, and welcome to the GNI Grand Rounds. We are very honored and great pleasure for me personally, and I think all of us here at GNI, to introduce someone we all know and love well, Dr. Peter Gliebus. For those of you that don't know that are joining, Dr. Gliebus is currently the chair, the chief of neurology and the director of the cognitive and behavioral program at the Marcus Neuroscience Institute at Baptist Health, Southern Florida. He's an associate professor of both at Drexel as well as Florida Atlantic University, and is the past chair of the Department of Neurology at Drexel University College of Medicine. Dr. Gliebus is a fellowship-trained cognitive neurologist. He did his training in Chicago at Northwestern University. He has more than 15 years of experience in cognitive neurology and neurology overall as well. He has incredible experience teaching both fellows, residents, medical schools over the years, which he's consistently won awards for teaching, Dean's Honor Award for excellence. It goes on and on. It's in numerous national and international Alzheimer drug trials, including studies with anti-amyloid monoclonal antibodies. And obviously, this is a very hot topic today, is cognitive neurology globally. And so this morning, he's going to talk to us about Lewy body dementias and the diagnosis and management over the spectrum of DLB-PDD spectrum within Lewy body. So I don't want to take any more time away from you because I know everyone's really anxious to hear this. And Peter, it's incredible to see you and look forward to your talk. Thank you.
Errol, thank you very much. It is definitely my pleasure to be back. When we connected this morning with Nicole just to check the system, etc., it felt like, the good old times, another Friday morning, with a GNI Grand Round. So anyway, good morning, everybody. It is definitely my pleasure to be with you. And I'm just going to share. And as Dr. Vess said, today I'll be talking about the Lewy body disorders, and I'll explain, I hope during the talk you'll understand why just lumping, the dementia of Lewy bodies and Parkinson's disease dementia into one group as a Lewy body disorders, because the distinction sometimes can be a little bit murky. So when it comes to disclosures, I really, as of now, I'm not on any speaker bureaus or anything. I used to be on the ASI for speaker bureau, but I think I have to report that for 48 months after stopping the relationship. But anyway, no disclosures, no pertaining disclosures to this presentation. So today, or after this talk, I hope that you'll be able to recognize the core clinical features of dementia of Lewy bodies and Parkinson's disease dementia and differentiate them from Alzheimer's disease and other dementias. Also, to apply the current diagnostic criteria and supportive biomarkers such as DAT scans, PSG, MIB, and emerging alpha-synuclein seed amplification assays into the routine practice, and also to implement evidence-based treatment strategies for cognition, neuropsychiatric symptoms, Parkinsonism, sleep disorders, and autonomic dysfunction. As you will see, these conditions are truly affect multiple systems, and people presents with a motor impairment, with a cognitive impairment, with significant psychiatric symptoms, sleep impairment, autonomic dysfunctions. So what is the underlying neuropathology, or the unifying underlying neuropathology for these conditions, for the dementia of Lewy bodies, Parkinson's disease, and Parkinson's disease dementia? And as the name implies, it's a Lewy bodies and Lewy neuritis, and those are the aggregates formed from hyperphosphorylated, misfolded alpha synuclein. If you look at the Neuropath slides, and here is the slide from the slides from the substantia nigra, you see the hyperpigmented neuron of substantia nigra. You see this Lewy body, and it is very easy to recognize them under the microscope because they have this solid core and the halo around it, and it's a different staining again in the hyperpigmented nerve cell, and you see this solid core and the halo around it. The Lewy neurites are just dystrophic neurites. They're formed out of the core is hyperphosphorylated alpha-synuclein, but also the debris from the axons and other cellular products. Now, the Lewy bodies, they don't look as distinctly when they're in the cortex, but they still, if you look, you always see that core and halo around it. Now, the distribution, and we'll be talking a little bit about the evolution, about how where it's initially formed, but the distribution is everything in the neuro world. The location of the pathology, not the pathology itself, determines the clinical presentation. So as you can imagine, I was talking that it is a very multisystemic condition, very multisystemic syndrome. So that if we're dealing with the sleep problems, there's going to be Lewy body pathology in the sleep centers. If motor symptoms are present, then it's going to be in the motor areas. If it is cognitive, it's going to be cortical. If it is significant psychiatric, you'll see the cortical and limbic distribution. So again, the distribution, but the very classical would be brainstem, limbic system, and neocortex. There is a significant overlap with Alzheimer's disease. The more we look at overall at these, the age-determined disorders, we started seeing that it's really pure, and that actually explains the frequently clinical presentation, because I was like, well, it sounds to me like it's probably Lewy body disorder. But why is the patient so amnestic, something? And it might be that actually it's Lewy body disorder and also underlying Alzheimer's disease that is causing amnesia. And it's for us, for clinicians, to really determine which pathology is driving the clinical presentation. And that's becoming more, it used to be only the academic discussion, but right now it's becoming important, because when we entering the era of disease-modifying therapies, we have to really make a decision which pathology is a driving force, because so far the disease-modifying therapies are being approved only for symptomatic cases. Neurotransmitters that are affected, it's the acetylcholines and dopamine predominantly, but other neurotransmitters such as noradrenergic and serotonin transmitters are also affected by this disorder. And that also determines the clinical presentations. As you can imagine, the dopamine changes in the dopamine levels in the motor areas and the substantia nigra projecting to the hemispheric structures. That's where it will determine the motor presentation. But also dopamine is very important in our behavior determination, and other cognitive functions. So dopaminergic deficiency definitely plays a role. Acetylcholine, the cholinergic deficiency, is very pronounced in these disorders, especially in dementia with Lewy bodies. It's actually more pronounced than in Alzheimer's disease. That's why these people can actually have a positive response to the acetylcholine enhancing medications. And the centers that are affected is in the basal forebrain and in the brainstem. Acetylcholine is one of these. It's a neurotransmitter and neuromodulator. Neurotransmitter meaning that it, transmits the information, and neuromodulator, it affects the function of other neurons, and it is perfectly placed to modulate our attentional gateways through the thalamus and also cortical distribution. Now, what is it? How does the disease develop? The hypothesis is that the initial changes actually occur in the enteric nervous system in our gut, and also in the olfactory bulb. So if you really dig deep and talk about the clinical presentation with these patients, you'll frequently hear that the very initial symptoms could have been the loss of smell sensation, or significant changes in the gut motility, such as constipation. But anyway, what happens, this alpha-synuclein is a normal protein. We all have it. It is important in the synaptic transmission under normal circumstances, but when there are some sort of or environmental or genetic factors, such as genetic mutation or some toxins or oxidative stress or whatever is possible driving the initial changes for the disease development, this alpha-synuclein started getting high phosphorylated. It starts misfolding into the oligomers, protofibrils, and fibrils, and starts accumulating and interfering with the neuronal function. The misfolded pathological aggregates, they also act as seeds, meaning that when they come in contact with a normal alpha-synuclein, they induce the misfolding into that alpha-synuclein as well. It's like a prion-like distribution, and then through the network's anatomical connectivity, it starts propagating, and initially, if it is enteric system and olfactory bulb, obviously it gets into the brainstem nuclei and then cortical neurons. So again, it's a very prion-like distribution. It's the misfolding, seeding, and then templated misfolding is happening and propagating through the nervous system. When I just started, talking, I said, I called it the spectrum, and there is this continuous discussion whether these Lewy body disorders, should we even separate them into dementia Lewy bodies or Parkinson's disease dementia? And you see that, well, differences are there. Some of the differences are a little bit artificial, meaning that we just created them. It's not necessarily biologically based differences. But if you look pathologically, in the neuropathology and the dementia Lewy bodies, you see the early widespread cortical Lewy body distribution. It frequently coexists with Alzheimer's disease, with the amyloid and tau proteins, and there are very severe cholinergic deficits, early cognitive and psychiatric symptoms. And Parkinson's disease dementia, as definition, it starts with the Parkinson's disease, so initial pathology is in the brainstem, in the substantia nigra, and as it propagates, the cortical involvement appears later, and dementia emerges after years of motor disease. So again, the dementia Lewy bodies, it starts with a cognitive problems and cognitive and motor problems together, and Parkinson's disease dementia, it starts with a Parkinson's disease and then start getting involving the cognitive domain. Now, let's talk separately about the dementia Lewy bodies and about the Parkinson's disease dementia. The core features of DLB would include fluctuating cognition with pronounced variation in attention and alertness, and that is one of the most sensitive symptoms actually for this condition. You will hear complaints as, one day they seem fine, another day they are so confused they can't find the bathroom in their house, or sometimes they're perfectly fine, and sometimes they are barely responding. The fluctuations in cognition and attentional fluctuations can be so severe that sometimes these people go into these, unresponsive episodes. And this is something when I'm teaching students and residents, say, if you have an older person, slower older person, and you're evaluating in the hospital for the recurrent unresponsive episodes, and you excluded the cardiac causes, the neuro causes such as seizures, and the changes in the circulation, etc., and you really have no good explanation. Think about, could it be actually this underlying synucleinopathy, underlying Lewy body pathology that can be causing these fluctuations in cognition and pronounced variations in attention? These people frequently, because there is a very early temporal limbic involvement, they have the recurrent, well-formed and detailed visual hallucinations. The REM sleep behavior disorder, and REM sleep behavior disorder is a dream enactment that occurs during REM sleep when there is a loss of the normally occurring atonia or paralysis. Can occur, a decade even before that, before the occurrence emergence of other symptoms. It's a very more prevalent in dementia with Lewy bodies than in other conditions. Again, not everybody has it, but but it occurs very frequently. And Parkinsonism, the Parkinsonism frequently is a little bit less pronounced than in PDD case, but it presents with a typical Parkinsonism, asymmetric bradykinesia, rigidity, resting tremor, or postural instability. Now, the supporting features for DLB would be severe sensitivity to antipsychotic agents, especially to the older ones, such as haloperidol. And it can be so severe that people can go into this freezing akinetic state for days after receiving even the smallest dose of these agents. The postural instability and repeated falls. And again, all of these Parkinsonisms, they have it because those centers also regulate our postural stability. It's probably not as pronounced as would be in the PSP, but it's there. Syncope, severe autonomic dysfunction. And again, frequently we see people with orthostatic hypotension, constipation, urinary incontinence. And again, the autonomic symptoms, especially orthostatic hypotension, might not be as severe as multi-system atrophy, but it's frequently present as well. Now, while REM sleep behavior disorder is very typical for dementia with Lewy bodies, these people also can present with hypersomnia and hyposmia. Now, as typical, very well-formed, complex visual hallucinations are very frequent and typical for the dementia with Lewy body patients, but they also might have systematic delusions, apathy, anxiety, depression, meaning any other psychiatric symptom. Now, Parkinson's disease dementia, the other end of the spectrum, they have to have a diagnosis of Parkinson's disease preceding dementia by at least 1 year, and that is probably one of the biggest distinctions because everything else, when you say it's more pronounced in this and less pronounced in that, when you have an actual patient in the room, how can you possibly say whether it's, in which spectrum would it pronounced, does it fall? But probably one of the hardest, criteria is the diagnosis of Parkinson's disease preceding dementia by at least 1 year. Again, this is a little bit artificial distinction in the sense, we created it. It helps in research. It helps in classifying these patients. I'm not sure how biologically sound this distinction really truly is. Now, after they were diagnosed with Parkinson's disease for a year, it's usually several years, they start to slowly develop progressive cognitive decline. They also have impairment in attention, executive function, visuospatial abilities. Memory impairment, they might have it, but definitely less severe than in Alzheimer's disease because by definition, the synucleinopathy is not the pathology that affects the limbic memory related areas. And they develop behavioral changes such as apathy, depression, or hallucinations. Now, supportive features of PDD. Again, visual hallucinations, less complex, and this is it's when you look at it as a group, they're less complex than DLB. But when you have a patient that this distinction becomes a little bit less helpful. Then these patients also might have delusions and paranoia. REM sleep behavior disorder, obviously REM sleep behavior disorder is very prevalent in Parkinson's disease. So the same applies to Parkinson's disease. Dementia is just an extension of Parkinson's disease with time. They might have also prominent fluctuations in attention and alertness, but it's less frequent than DLB. They're sensitive to antipsychotic medications and they have autonomic dysfunction. So, if you step back and put, I actually just now thought I wish I had those, two slides side by side. Sometimes clinically it's not easy to distinguish really, and to call is it a dementia of Lewy body or Parkinson's disease dementia. So if you are sometimes as confused as everybody else, just use the timing and that will help you the most. Then you might start seeing, the subtleties and subtle changes. But anyway, in the DLB case, the dementia starts before or within the first year of Parkinsonism onset, and in PDD, dementia develops more than 1 year after established Parkinson's disease. The cognitive profile, The DLB often shows greater fluctuations, but again, PDD might have fluctuations as well. And both of these conditions really have the frontal, cortical, subcortical, visuospatial deficits. And the PDD shows some memory decline, but again, that could be also the co-pathology. Hallucinations, both of these conditions might have visual hallucinations, but they're more frequent and complex in the dementia of Lewy body cases. And motor symptoms, by definition, the initial presentation in Parkinson's disease and more prominent early in PDD and less pronounced in early DLB. Both of these conditions are sensitive to neuroleptics, but it is one of the key supportive features for DLB. We usually, we don't try that to help us to diagnose it. We actually try to avoid it because it might have a poor outcome. But if these patients happen to get the older antipsychotic medications and that akinetic state or significant worsening happens, that can help you establish a diagnosis. And REM sleep behavior disorder is really not the difference. It's both of them have it, but if you look at it as a group, it occurs earlier in dementia of Lewy bodies. Now, how do we manage the cognitive symptoms? If you look back in the neuropath changes, we're talking that these patients have severe cholinergic and also dopaminergic dysfunction. So what you want to do, you want to target, and with what we have, we want to target these systems. Now, the DLB, if you add the cholinergically enhancing, the acetylcholinesterase inhibitor to a patient with Alzheimer's disease, you will rarely see the true improvement, okay? It's more maybe stabilization or, the functional, slowing down the functional decline, but in people with DLB, you can actually see improvement, and they will report, oh, they started this medication and they don't have these cognitive fluctuations and their attention is significantly better, et cetera. So if you'll start, your rivastig means your donepezil for these patients, you frequently might have a positive response. And then when you'll be treating motor symptoms with dopamine enhancing medications, it can add further to the cognitive improvement in these patients. And again, the rationale for the treatment is to enhance the cholinergic transmission, and that also, when I'll be talking about the psychiatric symptoms, it frequently reduces their psychiatric symptoms, especially hallucinations as well. So the evidence-based medications, rivastig, shown to improve cognition, attention, neuropsychiatric symptoms in DLB. Donepezil, evidence supports improvement in cognition and behavioral symptoms. Memantine, not cholinergic medication. It has a mixed evidence, might help some patients with global functioning and behavioral symptoms. And, obviously, we have to avoid anticholinergic medications because there is such a severe cholinergic deficiency that adding anticholinergic medication might worsen cognition and trigger delirium. Psychosis management. The visual hallucinations, delusions are very common and can be often distressing to the patient and family. And when we're managing psychotic symptoms, it really requires balancing the safety because, if you look at the antipsychotic medications, they all carry a black box warning to increase mortality, people with dementia. So you have to balance safety, whether is it really the medication that should be the first step. And sometimes if visual hallucinations are non-threatening, non-disturbing, they just see, person sometimes jumping on the bed or something, and you can distract, that would be probably the best, treatment for that particular patient rather than going into the medication because the medications have possible side effects. Now, evidence-based approaches, again, cholinesterase inhibitors like rivastig or donepezil should be the first-line therapy. It may reduce and actually frequently reduce hallucination and behavioral symptoms. Sometimes we have no choice and we have to use antipsychotic medications, but we have to do that with extreme caution due to high sensitivity in dementia of Lewy bodies. And quetiapine, the Seroquel, would be, the probably used most frequently. And clozapine, it's effective, but really requires blood monitoring. There is so it's not just easy to prescribe clozapine. The pimavanserin, it works not through the dopamine, but through the serotonin system. It's approved specifically for Parkinson's disease, psychosis, and under study in the DLB, and actually other psychotic symptoms in other dementia syndromes. And because of that's possible severe sensitivity to antipsychotics, you really have to avoid what we call typical or older antipsychotic medications as haloperidol, as these people can really be very sensitive, and that might even increase their mortality if you're going to use those medications. The motor symptom management, the goal is to improve function without worsening cognition and psychiatric symptoms. And sometimes it's easier said than done, because if they have severe hallucinations and they're very Parkinsonian, which one do you treat? Do you do the antipsychotic medication for hallucinations, or do you do the prodopaminergic medication for the motor system? Now, the dopamine therapy may help motor symptoms, but risk worsening or inducing psychosis, and worsening or inducing dysautonomia as well. The main thing with the management of motor systems, you have to start low and go slow. And evidence-based medications would be levodopa, carbidopa, modest improvement in rigidity, bradykinesia, tremor, less robust than Parkinson's disease. Avoid or limit dopamine agonist, the COMT inhibitors, MAO-B inhibitors. The anticholinergics and amantadine are usually not recommended. It is beyond the scope of this talk to talk about non-medical interventions for the motor symptoms, but that just for everybody to be aware that sometimes if people fail the medical management and their dementia syndrome is not as pronounced, nobody would use surgical intervention for a patient with DLB, but if it is PDD with a very mild cognitive changes, there might be considered surgical interventions. But again, it's beyond the scope of this talk. Autonomic symptom management, as I said, it happens very frequently. The autonomic system is affected. They can be very disabling, especially orthostatic hypotension, constipation, urinary incontinence, sexual dysfunction. The approach, the non-pharmacological first, and then you add targeted medications if needed. What does the evidence say? The orthostatic hypotension, you start with a non-drug use, non-drug such as compression stockings, increasing fluid salt, and slow position changes, training of how to change position, training, how to tighten which muscles, upon sitting or standing. And then if none of that works, then you can proceed with medication managements. The mitogen, the vasoconstrictor, but carries the possibility of supine hypertension, droxidopa, which works at which is enhances the norepinephrine, or it's norepinephrinic medication, and can help the synaptic transmission within the ganglia or at the nerve endings. Fludrocortisone, that increases the sodium content in your system as well, and that drives the fluid. And then pyridostigmine, which is procholinergic, used in the myasthenia gravis patients, but what it does, it's at the ganglia level, by increasing acetylcholine transmission, it helps with can help with the orthostatic hypotension, that regulation. Now, constipation, it's a fiber fluids inactivity. If that doesn't help, that would be your osmotic medications or stimulant laxatives. The urinary dysfunction, the bladder training, time voiding, caution with anticholinergics. Again, you hear again and again that anticholinergic medications, they're not good for the cognition, they're not good for the autonomic dysfunction as well. Sexual dysfunction, that would be your PDE5 inhibitors, may be effective if there are no contraindications. and REM sleep behavior. So there are many systems, because it's a multisystemic disorder. The REM sleep behavior disorder is frequent, vivid dream enactment and behaviors, risk of injury. So one thing, if it is an older person, especially with Parkinsonism, we probably don't need to do any additional studies. If they start acting out their dreams, screaming, shouting, punching, falling out of bed, that's REM sleep behavior disorder. But if you have somebody who doesn't have any other symptoms and you're having this dream enactment behavior, especially at the younger age, the sleep study is needed, because, the dream enactment nightmare type of nightmares can also occur during the slow sleep, and that's not REM sleep behavior disorder. And any phenomenon that occurs during the slow sleep, it doesn't carry the risk of future Parkinsonism type syndrome. But anyway, why do we even, is it, if they're just enacting their dream, why do we care about it? They can injure themselves. They fall. I actually had a patient who broke some bones while falling out of bed during one of the nights. And also they can injure their bed partners. And I've seen some significant injuries with the punching and everything. The REM sleep behavior disorder is highly prevalent in the synucleinopathies, and you always evaluate the safety first, and then how to make these patients safe and also preserve their sleep quality. So management strategies, non-pharmacologic, the safety modifications, padded surroundings, remove sharp objects, bed partner precautions, avoid alcohol or SSRIs. SSRIs can can affect that sleep atonia as well. So if there is a partial loss of atonia, this SSRIs might push it to the complete loss of this REM sleep associated muscle atonia. The medications with evidence, we usually start with melatonin. It's first line, well tolerated, safe in elderly people, and if that doesn't work, then go to clonazepam, and that's almost guaranteed to work. It's very effective medication, but we have to be cautious about that about those medications because of the possible daytime sedation, falling, worsening cognition, especially if these people need to go to the bathroom at night. That might be a risky medication, so you have to weigh which is riskier, the actual REM sleep behavior disorder or using this medication. And there are some other medications under investigation, such as rivastigmine, pramipexole, and memantine, but all of that is so far with a limited evidence. Neuropsych profile in Lewy body dementia. So you see, as I said, this attention, it changes in the attention, executive function, and visuospatial deficits. The memory and language are usually preserved unless there is a co-pathology with the Alzheimer's disease or vascular. But your classical is attentional, executive, your frontal, cortical, subcortical with visuospatial deficits. Now, the key differentials in Alzheimer's disease, the typical Alzheimer's disease, it would be the memory impairment. It dominates early. The cognitive fluctuations are a core supportive feature for the DLB. So again, just to summarize, the DLB typical profile would be subcortical frontal with visuospatial rather than primary amnestic. Now, I'm going to shift my gears right now to the diagnosis of these conditions. Now, clinical features are always, clinical presentation is always going to be the driving force when it comes to the diagnosis, but sometimes, especially if the symptoms are mild or symptoms are not very typical, we might need to implement the supportive test in order to diagnose. And what do we evaluate? Under currently what we have is we're looking at can we prove that there is a dopaminergic deficit due to a degeneration? Can we prove that there is autonomic dysfunction? Can we prove that there is a REM sleep behavior disorder? And also we started having the assays that actually directly evaluate for the presence of phosphorylated alpha-synuclein. That would be the direct biomarker confirmation on the disease. And while we don't have the disease-modifying therapy for these patients so far, it is increasingly important for early diagnosis and especially for the clinical trial enrollment, because we want to make sure that with the people who are enrolled in the clinical trial, that they have a disease that the trial targets. So the how do we evaluate for dopaminergic deficiency? It's your, it's your SPECT scan, that scan, the dopamine transporter scan, and it detects the reduced striatal dopamine transporter uptake. So we see the signal changes in a striatum in the basal ganglia, but it's really what we're evaluating those pathways, those tracts, projections from substantia nigra to the basal ganglia. And it's useful in distinguishing DLB-PDD PD from Alzheimer's disease. It's obviously we use it for, not only for that, but, sometimes, use it in the ET with a developing Parkinsonism, or, whether that for the tremor evaluation. Fairly good sensitivity, very good specificity, and FDA approved for clinical use in DLB. But not routinely used, but in cases when we need that support for the diagnosis. There are some limitations. It's costly, it's not widely available, and sometimes can be, some might have false positive in other Parkinsonian syndrome. So it's always, the clinical presentation. Does the clinical presentation make sense? Autonomic testing, don't do that very frequently, but sometimes if you need to do, you can get it, and you can evaluate. You can implement tilt table tests for orthostatic blood pressure monitoring, especially when you're having the question whether it's really orthostatic hypotension or are we dealing here with vasovagal episodes, because the management might be a little bit different. Heart rate variability, there is some changes because there is changes in autonomic, how autonomic system innervates the heart. Pseudomotor function testing, rarely do that, and it can support the diagnosis. Again, it just can prove that there is autonomic dysfunction and guide the symptomatic management. Sleep studies, the polysomnogram, that can help diagnose people with REM sleep behavior disorder. And again, it's when somebody already has other symptoms, the presence of the sleep the sleep enactment is REM sleep behavior disorder. But in cases when there are no other symptoms or a younger person, we can actually proceed with a polysomnogram and evaluate whether sleep enactment are we having does it occur during the REM sleep, or is it something that more slow wave sleep phenomena. It's fairly high diagnostic specificity for synucleinopathy, helps distinguish, as I said, RBD for other parasomnias, and can precede dementia diagnosis by years, by decades, and it could be the early biomarker. Now, direct alpha-synuclein detection, and there are a couple of ways to do it, and one is the skin biopsy, skin punch biopsy. So the cutaneous nerve fibers can contain phosphorylated alpha-synuclein, and in many synucleinopathies. It's not only in the DLB, PD, or PDD, but also MSA has very pronounced positivity for these tests. And you really do the punch biopsy in 3 areas near the neck, in the thigh, and in the calf, and you do the immunostaining and evaluate for the presence of phosphorylated alpha-synuclein. Early guide sensitivity and specificity from multi-site studies. Numbers can vary, but it's fairly reliable test. Minimally invasive, promising clinical diagnostic tool, and we are already frequently implementing especially in the cases when we do need not a clear-cut cases, and it's also it can be used in research in order to confirm the presence of the disease. The other way also to identify the presence of hyperphosphorylated alpha-synuclein is by seed amplification assay in the cerebrospinal fluid. So right now, actually, in the cerebrospinal fluid, we're evaluating somebody with a neurodegenerative disorders, especially if if it's unclear, we can actually get the Alzheimer's disease biomarkers and alpha-synuclein as well. It's done through, it's not done in the hospital lab, so it needs to be shipped to a specific lab, and it's fairly fast turnaround time. So they detect the study detects misfolded alpha-synuclein aggregates. It's also very good sensitivity and specificity for the DLB and PDD patients. It's still currently research-based, but more and more, especially in appropriate patients, we started using in the clinics as well. Additional studies, that's a mistype. The first one, it has to be FDG PET scan, the fluorodeoxyglucose PET scan. And there is in the typical cases, there is a difference how it looks, what does Alzheimer's hypometabolism look versus what does the dementia with Lewy body hypometabolism look. As typical, as a reminder, the Alzheimer's typical hypometabolic pattern would be your temporoparietal, more associative cortex, hypometabolism, the presence of it in other areas involved as well. Now, in the typical DLB, we have more posterior predominant hypometabolism, the occipital hypometabolism with spared cingulate. Again, that's what's called the cingulate island sign. Now, why cingulate? Because cingulate is actually is affected by Alzheimer's disease. The cingulate, posterior cingulate region is one of the first areas where the amyloid starts aggregating. So if we have the sparing of occipital lobes but involved cingulate, that would be your Alzheimer's pattern. If you have involvement of the occipital lobes, sparing of the cingulate, that would be your DLB pattern. And again, we have to remember that there are atypical Alzheimer's presentations, such as posterior cortical atrophy, that might have, that this rule might, with the occipital sparing, might not necessarily apply. Now, MRI is definitely non-specific, where you use it frequently to exclude other pathologies. But if in the typical, in the clean DLB cases, we would have the hippocampal volume, the smearing of the hippocampal volume. It's very non-specific, but because the DLB frequently goes hand in hand with Alzheimer's disease, having hippocampal atrophy, having involvement of medial temporal lobe structure should not defer you for making a diagnosis DLB if clinically it is DLB. Now, cardiac scintigraphy, it's evaluates sympathetic innervation in the DLB patients. It's used more in other countries. I've never used it, never ordered it, but it's out there. And EEG demonstrated generalized slowing, some changes in occipital dominant rhythm fluctuations. It is, again, supportive, but it is not a specific finding. So all of these, probably the FDG PET and cardiac MIP would be, you can find more specific findings. Everything else is very non-specific. So just to summarize and just to put the take-home messages for the Lewy body disorders, the core clinical features, the fluctuating cognition, visual hallucinations, REM sleep behavior disorder, Parkinsonism. We can use supportive biomarkers to help making the diagnosis, such as DAT scan, cardiac MIP, PSG, and more right now. We started relying on mentioned alpha-synuclein assays, whether it would be through the skin biopsy or cerebrospinal fluid analysis. Differential diagnosis, rule out Alzheimer's disease. It's not differential diagnosis, but how do we differentiate dementia with Lewy bodies with Parkinson's disease dementia? So that use that 1 year rule. If the motor symptoms started initially and for at least 1 year, it was only motor symptoms, and then they developed cognitive and other symptoms, then you say that it's Parkinson's disease dementia. If dementia occurs first or together with motor symptoms or within first year of motor symptoms, then we would call that dementia with Lewy bodies. And again, the clinical presentation differences are they're subtle, not very distinctive. So use the 1 year rule. And obviously we have to exclude the mimics such as vascular, medication induced, the NPH, etc. Treatment. you see the colors because I had another scheme, but I didn't use it. But anyway, the cognition, treat the enhanced cholinergic system, can use memantine. The neuropsychiatric symptoms, avoid antipsychotics, avoid typical antipsychotics for sure. Now, as a first line, as I mentioned during the talk, again, use cholinergic system enhancing medications first. And if that doesn't work, then can try low doses or clonidine or use pimavanserin. For the motor symptoms, levodopa is standard. Use lowest dose possible. Avoid dopamine agonists and for sure anticholinergic medications. For the sleep disorders, melatonin first line, then move to clonazepam. For orthostatic hypotension, non-medications first, then you move on to medications such as mitogen, fludrocortisone, droxidopa, pyridostigmine, and constipation, urinary dysfunction. It's supportive care, the same as you would treat the constipation or urinary dysfunction. References, not all of them, just some of them. And thank you. I think that will be it.
Peter, that was great. Thank you. I'm going to summarize some of the questions because there's a lot of overlaps. So before I do that, for everyone to claim your CME credits, you can see on the web chat there, you can just click onto that link and you'll be able to get your credits. So there's a couple, again, I'll kind of consolidate these. One is, what are your thoughts on the newer agents that are thought to slow the progression of diagnosed AD? I think Leqembi, and the other one is Kisunla.
Yeah. So the lecanemab and donanemab, the monoclonal anti amyloid medications. And again, this is nothing to do with the Lewy Bodies, but if we're talking about the just for for people who listen, that's for Alzheimer's disease. So they are shown to slow down the disease progression. They slow down the speed of the progression by 30 probably plus percent. It's always managing, the risk, because these medications do come with risks, possibility of, the swelling or bleeding. The good thing, even if the swelling or bleeding occurs, 80% plus, 8 out of 10 patients will not have any symptoms. We find that on the MRIs just because, during the monitoring process. So we do use these medications. I have some patients who we're infusing, and for a year we don't see necessarily the progression, but that's not the rule. People by definition, they have to, they are progressing. It doesn't stop or doesn't reverse. So those medications perfect? Absolutely not. Are they expensive and requires a lot, the infrastructure? Yes. But that I think that's a good first step moving to try to affect where the way I say, where the cancer medications or HIV medications were the first medications, were they perfect? Absolutely not. But that is a ground to move forward.
Okay, and I'm not sure if the context was, is there a role for any of these agents in LBD?
No, so there is no, except, and I have several patients like that when we see that there is a dual pathology. As I mentioned, these conditions frequently go together, and that's where it comes, to the which pathology drives, is that because people might have amyloid in the brain and, for a decade, 2 decades, and it's doing nothing. So you don't treat it, it's inappropriate to use those infusion medications, but some patients might have, some, Parkinsonism. You actually have the positive DAT scan, you have some maybe hallucinations, but they're severely amnestic. They have significant medial temporal lobe involvement. And you have the confirmation of the amyloid presence as well. Then in that case, if you believe that it is a driving force, you can use it. Again, you have to be very transparent with the patient that we're talking here about the two diseases. The prognosis does not, and the response to the medication, what we know of, does not apply to them. because they're on the faster trajectory. So in this context, it could be considered, but there are many variables that have to be discussed with the patient also, and only then this decision can be made whether to use that or not, to use those medications or not.
Got it. And the other question is, there's a couple of questions on this, on the age of a diagnosis in Lewy body dementia, that there's subsets in Alzheimer's where you can see a younger onset, which is usually more aggressive, I believe.
Yes.
And then in Lewy body dementia, is there any correlation with that? And is there any prognostic versus being diagnosed younger as opposed to later?
Yeah, it doesn't, it could be the younger, and then, when the younger, then we do, the question, especially, if the Parkinsonism was the first one, whether there could be, the genetic, component that is playing a role in developing. But it's usually, that typically it's the, well, older when I'm moving that direction becomes relative, but overall it's the past the midlife disease. It's rarer to see young people with dementia Lewy bodies.
Okay. And then the other, I think kind of there's a bunch of these at 30,000 feet. There are lots of theories, obviously, for both PD and Lewy body. For Lewy body in particular, what are your thoughts of all the theories? And the obvious being a combination of genetic, environment. What are your thoughts on etiology?
So the what are those factors that start cause or induce that misfolding and hyperphosphorylation? That's a very good question. Yes, there are genetic causes. Some are clear. We don't have to discuss it, but the environmental factors, the toxins. There are these. The data showing the possibility, and I don't remember the exact chemicals, but in the dry cleaning, that can actually be because such a high prevalence in people who own those business and everything. That can be present. Then the other toxins that are environmental. So is it playing a role? Absolutely. Can I pinpoint to one? Probably not. But there is there is some evidence about, as I mentioned, specific chemicals can be found in the water, can be found in the dry cleaning, can be found in other things that definitely, when people are exposed, that can increase the risk of developing these conditions.
Got it. And then I'll just, for time's sake, I'm going to ask kind of the last question here. My question is, what are you most, with everything going on right now, and I'm sure, especially in the neurosciences, we're being almost choked to death with AI. Everyone's trying to figure out AI to solve every problem on the face of the earth. But between imaging, using things like artificial intelligence for diagnosis, and some of the other, again, things that we're seeing that are slowing, particularly as you mentioned, the PD side of it. What are you most enthusiastic about right now as far as, the last 5 years where we are now?
So when it comes specifically to AI, and AI did contribute already, to understanding. Like, I'm going to pivot a little bit to the Alzheimer's disease. It's the California group. They using AI, they were able to identify that one of the chemicals, one of the enzymes, actually. We thought that enzyme is just, a marker of Alzheimer's disease, but actually the AI helped to understand that the changes in that enzymatic activity can be one of the triggering factors of amyloid, changes in the amyloid cascade. And it went even further. It helped to identify already known chemical that can affect that enzyme. Specifically, doesn't affect the other functions, but just affects that function with the amyloid. Okay, so is there a role for AI? Absolutely. Is this going to replace everything? No. But in a very specific, because your AI is as good as it's taught. Okay, it's so if it has a bad teacher, bad information, it's going to be a bad, bad decisions will be made there. So, but if you have a very clear function for AI, to teach something very in that box, it can play a great role. Diagnostic wise, the AI probably can be better, finding, subtle things on imaging than we are, so if it is, it's already playing a role. It's not going to take over everything. AI, as I said, it's as good as what is being taught. If the information is poor or poorly put into AI, it's going to be a bad function.
Are you or your colleagues using anything for like intake for patients, like helping? Because there's a lot of these platforms now where basically AI is writing your notes for you in the office, but to be able to collect data to look at maybe common denominators amongst patients that are coming in with minor symptoms versus more severe.
We're looking into some things, but we're not using it. And the medicine is always a little bit more on the conservative side. So it takes time for the change to happen. And
Right. Well, Dr. Gliebus, thank you so much. It's great seeing you, and I know I'm getting a lot of texts about how great it is to see you and hear your voice again. So good luck in Florida, and we hope to see you soon. Thank you for this.
Absolutely. Thank you for having me. It's my pleasure.
Bye-bye.
Bye.
Have a great day, everyone.